Welcome to the webinar. It is the latest in a series of discussions about aspects of improvement science organised by the Health Foundation. Our topic today is achieving value in hard times. Health and social care services across the UK and for much of the rest of the world are facing hard times, times that call for tough decisions from those responsible for planning services and allocating healthcare budgets. Today we'll be exploring what we can do to meet this challenge. My name is Bill Lucas and I'll be facilitating our discussion. With me are two experts on the topic, Gwyn Bevan and Anita Charlesworth. Gwyn Bevan is Professor of Policy Analysis in the Department of Management at the London School of Economics and Political Science. He's been head of LSE's Department of Management and a director at the Commission for Health Improvement. His current research in healthcare includes comparisons of performance across the countries of the UK and applying a new approach to priority setting, STAR, that's socio-technical allocation of resource. Gwyn, you're very welcome.
Thank you very much.
Anita Charlesworth is Chief Economist at the Health Foundation and a non-executive director of Whittington Health NHS Trust. She has previously worked at the Nuffield Trust, the Department of Culture, Media and Sport, and Her Majesty's Treasury, where she led the Wanless Review team. Anita, welcome. In a moment, I'll invite Gwyn to present, and Anita will then respond to his suggestions. But before I do so, let me remind you that these webinars work best when they are truly interactive. In other words, we need to know what you think about how we achieve value in healthcare. Do please let us know by sending us your comments from now onwards. After our two expert inputs, I will do my best to put your comments, your ideas, your suggestions to Gwyn and to Anita. So, without further ado, let's get started. Gwyn, tell us how we can achieve better value in hard times.
Well, thank you very much, Bill. It's a great pleasure to be here as part of this webinar with Anita. And the approach I'm going to talk about to achieve value in hard times is, as you've described, the socio-technical allocation of resource, the STAR approach. And it's very appropriate. This is part of a Health Foundation webinar, this based on research that the Health Foundation funded for over 8 years. And the point I always make about this took a huge amount of research looking at intellectual approaches to and theories of priority setting. In the end, we've come up with something that's relatively simple and I hope people will see as actually applied common sense. The way I've structured the introduction to this webinar is to talk about the way in which STAR looks at the way we relate data to decisions in a different way from what normally happens within healthcare organisations trying to decide how to use money to increase value in times of limited resources. And a key part of the development of that to enable them to make better decisions is to use models. And for us, a fundamental part of the process of reallocation of resources is it's absolutely vital that we engage the stakeholders who are involved. And that will obviously include the managers from purchase and providers of healthcare, the clinicians who deliver healthcare, and we also think it's tremendously important that we include patients and carers, the people who experience care. And although people within healthcare organisations are often reluctant to do that, we think this is very low risk and has huge potential benefits, which I'll describe. And at the end, I'm going to talk about two applications of STAR within the English NHS and in a developing country. So in terms of data models and decisions, the problem that we typically face in healthcare organisations trying to decide how to improve value for their population, and they want to look across interventions and decide how to do that. When they try and compare interventions, the conventional approach is like what we describe as a technical approach, where you start with the data, you put it into a model and you make decisions. Now, the difficulty you have is that the data that are readily available puts you in the position as graphically described as horse and rabbit stew. And the way you make this stew is you take a horse and you take one rabbit. And the real problem with that is that the flavour of the horse can dominate the stew, or it could be the flavour of the rabbit would dominate the stew. The rabbit in this case is the bit that which you have good, complete data to which you imply the model to inform decisions. And there's always this uncomfortable feeling that the horse, the most important bits, have been left out. So once you've got the results from the model, you're really perplexed as to what to do with it. So the socio-technical approach engages stakeholders in an interactive process of using data to model to tell us what data to collect. We put the data in the model to see what impact they'd have on their decisions. And we keep on checking the data. In the end, we believe we've got robust data through sensitivity analysis that mean we're confident in the decisions on change we need to make. Now, the problems we face, which is what the STAR approach is designed to tackle, is how on earth do we measure the horse without there being data being available? And when we put together different sets of data, estimates from stakeholders alongside data that are routinely available, how do we know what data are decisive? And how do we know that we're making robust decisions, given all the data that we have from various sources are subject to errors? So for us, the interactive process that we go through is we start off with visual models, and the stakeholders, as I said, include managers, clinicians, patients, carers, and other agencies. And it's really important they understand how these data come together to inform decisions on value for money. So for us, the key to that is developing visual models that everyone can interpret and make sense of. And the visual models tell us that if we want to look at how we improve value for money, for every intervention we're considering, we need to look at its scale, its costs, and its value. So I'm now going to talk about the visual models that we developed that help us do that. At the heart of STAR is the value for money triangle. And this consists of, on the horizontal axis, for any intervention you have its total costs. The vertical axis is its total value. And the hypotenuse of the triangle is its value for money. Now, the great advantage of that is that people do not need to have a degree in economics to when the interventions are displayed like this in terms of their value for money. And you can see that the blue triangle on the left is an intervention that has very good value for money. For a limited spend, you get huge amounts of benefits. And the one on the right, the red triangle, is giving you very poor value for money, spending a lot of money for very little benefit. So what we do is to look at how care delivers value for money across the care pathway, different interventions. We sequence the triangles, the value for money triangles, in terms of the order of their slope. So we start with the intervention with the steepest slope, which in this case is A, then go to B, the second steepest, and finally C. And organizing these triangles in that sequence is what we call the efficiency frontier. So, for example, in this case, we've got these three interventions, A, B, and C. And another powerful advantage of using visual models is it also shows the scale of the different interventions. So here you can see that although the green triangle on the extreme right is worst in terms of value for money, we all know that to change what people do in healthcare, move resources around, is going to be a very costly business, take a lot of time and effort. So you want to make sure that you strategically target the interventions where you can get most benefit by focusing that effort. And here it's clear that you'd focus on the red triangle because scale is very important, and not the green triangle simply because it has the worst value for money. And if you do that, then the process of reallocation means that you can move resources, you can cut back on the spend on the red triangle and move resources to the blue triangle. And if you do that, you then get a massive increase in benefits and a reduction in costs because, of course, the red triangle is such poor value for money that a small reduction in that will enable major increases in the blue triangle that delivers good value for money. So we now look at how, in practice, you can develop these value for money triangles. And as I said, there are these two elements to that. There's total costs, which is based on numbers treated and cost per case, and the value, which is based on numbers treated and the QALY gain per case. This is our estimate of value using the idea of quality adjusted life years. So a QALY of 1 means a year of perfect health, and a QALY of less than 1 and just for the quality of life being less than perfect health. And typically the data that gets generated and available is you know about numbers treated, you know about costs, but you don't know about what the quality gain is. Now here the way in healthcare the problem of horse and rabbits do often manifests itself is particularly that we're missing data on value, as I said. And there are a few interventions where we have perfect data from randomized controlled trials, but for much of what goes on in healthcare, we have no information at all. And people think, therefore, we've got no information on value. And this creates a huge obstacle if you want to engage clinicians, patients, and carers in discussions about changing the way we deliver care, because if all you're going to do is to talk about costs and numbers, they'll think all they're taking part in is an exercise to reduce costs and not to increase value. So it's absolutely vital that you include information on value, but the problem we've got is the available data, it's typically not there. So this is a major stumbling block in conventional approaches. What we do is to say, actually, engaging stakeholders is the best way to estimate value. So for us, and our experience shows that stakeholders can estimate the relative benefits of different interventions. That puts us in a grey zone between perfect and information and none. But we'd also RCTs, findings from randomized controlled trials, are also in that grey zone, because what the outcomes you achieve in clinical practice in your area will typically be different from those in the RCTs, which are designed to exclude patients who are actually included commonly in terms of the routine delivery of care. So that's the theory and the way that we reframe the problem that we typically encounter in trying to have an evidence base for improving value for money for healthcare. I'm now going to talk about two applications. And the first one is on eating disorders in Sheffield. And here, this is where the mental health lead in Sheffield felt that there was something wrong with the way care was organised for the treatment of eating disorders and made a huge contribution to being a champion within the Sheffield to taking this work forward and getting people to come to meetings and take part in it and generate data. So the people that were involved were managers from the primary care trust, the purchaser, providers, patients and carers, public representatives and clinicians. And we had 2 one-day meetings, 20 participants. And the key emphasis here is we look across, change across a care pathway, and the data that we require, as I said before, are numbers, costs, and benefits or value per person. So if we look at one element of the care path, which is intensive residential care, this is the information that we have, and as typically within healthcare, we know what it costs. Totally costs about £1 million. Very expensive intervention, this. Cost per case about £60,000. About 16 people treated each year. But the thing we're missing is what the value is from this highly expensive intervention. So the way that we estimate value is to use methods of cost-effectiveness analysis in healthcare. So the starting point is to think about states of illness for eating disorders within a scale from 0, which is conventionally taken to be being dead, and 1 being in perfect health. So what we did here was to ask the stakeholders, we split them up into 4 groups, and to say, think about the state of health of a mild eating disorder. And we know that the quality of life for that is going to be 0 for 1. And we have what are called anchors. This is the evidence base that we have from studies of psychiatric disorders that enables people to think about where does eating disorders fit compared with these well-known psychiatric conditions for which studies have produced good evidence as to what the quality of life is. And in the end, the groups agreed that this was very similar to the state quality of life for some anxiety depression, 0.71, with a range about that in plenary recession. In the groups, they had quite a wide range of values. The point about our model is all these different ranges of values can be fed through the model, and you can do sensitivity analysis and see how the picture changes with changes in these input values. So for intensive residential care, what we did then was to engage the stakeholders to think about the states of illness the patients would have after a year if admitted, and what would happen if they were not admitted. So they worked out that the states of illness would be stay the same, which would be a quality of life of 0.1. You could get worse, a little improvement, become moderate, recover. And what we did then was to get them to estimate what the probability distribution would be after a year if they'd been admitted to intensive residential care, and what the outcomes would be if they had not been admitted. And then you get this average score across all these different states weighted by the probability, and the difference between them gives the gain, the value per person, the benefit per person, which is about 0.46 quality adjusted life years. So we can now complete the value for money triangle for intensive residential care. The quality gain per case is 0.46, its total value is 7.36, and we can put that in what we describe as the efficiency frontier. This is the different interventions on the care pathway ordered in terms of the steepness of the hypotenuse of the triangle, their value for money. And here we can see that the mental health lead in Sheffield was absolutely right. This is a poorly organised service in terms of value for money, because the residential intensive care accounts for 80% of costs and generates only about 13% of benefits. And as typically the case, when we look across care pathways, we find that the early preventive interventions, that's the triangle, the extreme left with these 1 to 2, is an early intervention in primary care, is estimated using subjective estimates to be highly cost effective, but provided on a very limited scale. And the other triangle of interest is 3 to 4, which is some intermediate stage of care before people require residential intensive care. And triangle 7-8 is at the extreme right, which is admission to an acute psychiatric ward, and that has the worst value for money of all. But again here, in terms of thinking about how can we improve value for money in this care pathway, you wouldn't worry about acute psychiatric admissions. There are a few of them. Even if you start to make very little difference to this care pathway, the thing you want to focus on is the red triangle of residential intensive care, which appears to be very poor value for money. Now, at this point, it's worth saying that two of the stakeholders were a mother whose daughter had died from severe anorexia and a woman who had severe anorexia. And you might think, as people in health service organisations would do, that bringing in patients and carers, they would be against any movement of resources, particularly in this case because the daughter and the woman who had severe anorexia would have experienced this stage of care. But they're both enthusiastic advocates of getting resources out from there into earlier in the care pathway. The mother saying, look, if my daughter had been picked up earlier, she might still be alive today. And the severe anorexic saying, you want to stop people getting like me. So again, what we do here, what the Primary Care Trust explored, was cutting back. This is the rectangle in the top left, cutting back on acute intensive care, moving resources into the intermediate care and into primary care, expanding those services. And again, because you're taking even a small number of patients out of this 16, moving a few of those will release huge amounts of resources. So you actually end up with much more benefit at reduced cost. The final example I give is from a developing country. This is options for tackling malaria. Basically, there are three options here. One is nets to stop malaria getting into you when you're asleep. The other is spraying where the places where people live. And the third is a diagnostic thing of early detection of cases. The indoor spraying, two approaches. One is to target villages, and the other is coverage for 25% of households at risk. Now, if you do the value for money triangles here, the blue triangle on the extreme left is what comes from hotspots spraying villages, and the brown triangle comes from spraying in terms of the population at risk. And you can see that the blue triangle offers much more value for money than the brown triangle. So it's much better to target villages than individuals at risk. Now, this is work we're doing with the Global Fund, and the key attraction for them is they find that that the countries that due to receive their funds, they find this a very natural way of applying the economics of cost-effectiveness analysis. And this is, again, what we find when we work with stakeholders, that they see this as a very natural way of thinking about how to improve value for money. So as I say, it's like applied common sense. This is the research team. I actually present the work. These are the people who actually do the work. And the current projects we've got is we're working with NHS England and Right Care, trying to implement this in the NHS in England. The Global Fund are keen to use this to enable countries to think about cost effectiveness in bidding for new funds. And we're doing research and development with a project in North Thames, an AHR project, trying to look at how you can most effectively integrate health and social care. And if you would like to use the tool, the Health Foundation paid PwC to develop this as a software program, you can download this from the web. And I just want to say we're very keen to hear about people. If you're interested in using this, do please get in touch with us, and we'd like to hear from you. Thank you very much.
Gwyn, thank you very much indeed. That's indeed the perfect request. So if you're watching and enjoying this and you have specific questions for Gwyn, or you'd simply like to log your interest in perhaps being a test site for this or finding out more or having a deeper conversation with Gwyn, then please just communicate with us right away and I'll try and bring out your comments and we'll have your information to get back to you about. So Gwen's got us off to a terrific start. I'm now going to invite Anita to respond with her thoughts on how we can improve value in healthcare today. Anita.
Thank you so much. STAR is obviously a technical tool, and what I want to talk about is why I think tools like this are so important and the sort of decisions that they can support. In order to do that, I'm going to focus on three things: the nature of the challenge facing the NHS in the future, the NHS recent experience in meeting that challenge, and some of the evidence on commissioning. So first of all, to look at the challenge. I think now we're all familiar with the beyond the current quick challenge, the need to deliver £20 billion of efficiency savings by 2015. That's, if you like, a first bite at the cherry, and the NHS is going to continue to need to deliver efficiency savings. Most people's estimates are of savings of around 4% a year over and above inflation for at least this decade. That's much more than has been traditionally delivered in healthcare, much more than is delivered in most of the economy. So it's a huge mountain that we have to climb. If we're going to meet that challenge, then we need to look not just to providers to deliver the care that they're already delivering more productively, but actually we need to deliver system-wide efficiencies. We need to do things differently. And this is perhaps most clearly set out in the recent planning guidance that went to commissioners and providers. That showed for the £80 billion of secondary care spending that in 2015-16, the challenge is not 4%, it's over 6%. In 16-17, it's another 5.5%. And in 18-19, it's again almost 5%. Now, most expectations are in that planning guidance that providers, if they carry on really focusing on efficiency, can make up less than half of that affordability gap. The rest needs to come from innovation, from system efficiency, from doing things differently. But the challenge is not just financial. The other thing that we've seen recently is the Commonwealth Fund's report on looking at a number of leading healthcare systems. And as people may recall, the UK, the NHS, came out top in the Commonwealth Fund survey. We deliver access very well, we're very efficient in many ways. But within that, there was also some very depressing findings, which were that on value, we were second bottom. And that was looking at mortality amenable to healthcare, so that's deaths, premature deaths that could potentially be avoided by appropriate healthcare. Child health also showed very poorly, and life expectancy at 60. In essence, this is what our healthcare system is about, using all of the funds that are invested by the taxpayer to make a real impact on health. And in that area, we clearly have more to do. We'll have more to do at the moment, and we know the needs of our population are changing. Experience to date is really that we've been very reliant on one-off savings, on the government's pay policy, on all the focus on reducing management costs, on the fact that a lot of our most commonly prescribed drugs are shifting off patent to generics, delivering cost savings. Those have all been really helpful, but they are temporary. They cannot continue. They are a tactic and not a strategy. And it's vitally important that across the NHS, we shift from tactical solutions to a more systematic approach to improving productivity and efficiency. As the Select Committee on Healthcare has commented over and over again, we're not seeing at the moment the progress on transformative change. That's understandable. Transformative change is really hard, but the need for transformative change is increasing and not reducing. At the moment, we've relied very heavily on tariff reduction, and the system efficiency savings have been relatively small. Also, it's clear that demand management strategies are struggling. The acute sector is continuing to grow as a share of commissioners' resources. There's more and more activities going on there. And there are increasing worries about cuts in mental health and primary care starting to affect the quality of care for patients. So clearly, commissioning in the future is not about simply running the same system a little bit better. It has got to be focused on transformative change. But equally, a number of reviews by the King's Fund and work by Judith Smith and colleagues at the Nuffield Trust has shown how difficult it is to achieve change through commissioning. We've had a range of initiatives over the last 30 years on commissioning. What comes out very clearly from that is that often the benefits are incremental, they're small scale. There's too often a focus on cost rather than on quality and patient experience, and clinical engagement is vital if we are to achieve change. Value for money as well is often not central to a lot of the activity, and it's much easier to focus on doing new things, doing incremental things, rather than looking at the core activity within the commissioning budget. But if we are to achieve value and meet both the financial challenge and almost more importantly, the healthcare and outcomes challenge that we face, we won't do that by focusing on the incremental and the small. We'll need to target our efforts much more on the core of services. It seems to me that STAR potentially is a really helpful tool for commissioners. As Gwyn showed in his presentations, it helps you to focus not just on where there's potentially poorest value for money, but where really there's the biggest impact in terms of spend and value. To focus those scarce commissioning resources, because commissioning is a tough job. Change is tough, it's highly resource intensive. So it's vitally important that that commissioning task is focused on the big things where it can really make a difference. The other thing which is really important here is that the research on commissioning shows that stakeholder engagement, particularly clinician engagement, is vitally important to success. The STAR tool embeds that clinical engagement in the process, and that seems to me to be another really important feature of these sorts of tools. So what I want to really emphasise is that commissioning needs to really embrace this transformative agenda. I think to be able to do that, given the scarce resources and the challenge of transformation, we really do need a strong evidence base and to utilise that evidence base in a way which engages stakeholders and helps prioritise effort. And STAR is one of the tools that I think can really help people in that. Thank you.
Great. Thank you very much, Anita. That's a wonderful strategic overview from Anita. And already really interesting questions coming in. If you agree with Anita, let us know. If you disagree with Anita or you have some nuanced difference of opinion, please share that with us. What I'd like to do now is come back to the STAR approach and take some of the questions that we have already about that. And as we go through the detail, then move a little further out and look out at some of the more systemic and strategic issues that were being raised just now. So let me start with a very specific question, if I might, Gwyn. This is from a colleague in Cornwall, interested to know whether the methodology could be used for public health community-based interventions at scale. Talking about a Live Well model in Cornwall, covering the 5 behaviours that cause 5 diseases that cause 75% of death and disability. Does this kind of approach work for that, do you think?
Yes, I mean, it can work. One of the attractions of this approach is that you can use it to look at public health interventions and acute care interventions. And some of the early work we did was looking at stroke care. At the time we were doing this work, the Department of Health was putting huge emphasis on thrombolysis and ensuring that all patients were cared for in a specialist stroke unit. And there is indeed good evidence this is highly cost effective. But what we found was that their impact on the total burden of disease was relatively small. And this comes back to, as Anita said, the scale effect is terribly important here. So something that's highly cost effective may not have a huge effect on scale. And what we were able to do was to compare these acute interventions with public health interventions like improving control of blood pressure and reducing salt in bread and cereals. And the great thing about this is, again, I just think it's so important. It's the point Anita made, which we see as fundamental to this. It's so hard to tease out where you want to focus your effort. So the scale of what goes on, just looking at these 5 interventions, just to get people to think about how many people would we expect to meet, how many people would you expect to benefit, what do you think the degree of benefit would be, what would the costs of doing that? And simply rehearsing those sorts of subjective assessments immediately sort of gets you to see, look, there are a few things here that don't appear to be worth bothering with, and there are a few things that we want to focus on. And I know that the data that we deal with is typically subjective, but again, as I emphasize here, we have an iterative process. You can start off in that way. You can then say, look, do these look credible? We have a model. You can play around with your estimates and see whether it changed the shape of the model. You can then say, look, we think this is what we ought to go for, but we're not sure about it. Then you see, can we do a literature review? Can we do more empirical research and feed it through? So the short answer is yes, it can be used for that.
No, good. And one more question, and then let me invite Anita to come in too. This is a question about another, can we use it in this context question. My understanding is that this has been used mainly at trust level. Could this approach be used at national level? And that I think also reads across to the point that both of you were making about the power of stakeholder engagement. And of course, the stakeholder is a different entity if we're thinking nationally as opposed to in Sheffield. So maybe both of you, would you like to just respond to that?
I think that we did do work with IMPRESS, which is this group of clinicians who are committed to improving respiratory care. This is on guidelines for chronic obstructive pulmonary disease. And this is at the national level, and what they found was that in terms of guidelines for change, again, you'd want to get some estimate, some feel as to which would have the biggest impact for different types of COPD and people who don't have COPD. And they found this enormously helpful in teasing through the guidelines you would estimate. So you can use it at national level, but for us, the attractive thing about doing it locally is that it's a concrete exercise, not an abstracted one. So people can think, as in the Sheffield case, you can visualize the service you're talking about. It's grounded in that way. It's grounded with real data. You can think about the people, think about the typical patient. And my preference in terms of attacking national issues would be to take a national problem and think about how it would be done in a local area. And then you design the exercise in such a way that other people can then replicate it. But I think that for me, if you want to get patients and carers and clinicians engaged, I just think it's so much more helpful doing it at the local scale.
Forgive me, both of my colleagues, if I cut across you. It's just that the questions are coming thick and fast. Anita, what's your view about that?
So I really agree with Gwyn about the importance of the national level. I think for 2 reasons. One is I think there's across the NHS, there's still a strong command and control. culture, and people locally don't want for instructions from the centre about what they should be doing. But local areas differ so much. I was a non-exec on a PCT in North London for a long period. And we had a demographic profile which was really different to many other areas. You know, we had a very high rate of under fives, very high rates of poverty amongst young children, very high rates of smoking from a very diverse population who had very high rates of COPD, and we were an area where a lot of people with profound mental health problems migrated to. And actually, where we would get our scale benefits in that demographic and health need mix was very different to where a national average picture of the burden of disease and the sort of opportunities would point you to. And part of the value of the STAR tool, it seems to me, there for a PCT like the one I was involved in, obviously now clinical commissioning group, is being able to reclaim your own agenda as well. And in terms of engaging stakeholders, particularly as you start to engage local politicians if you're trying to achieve change, local authorities, really rooting that in the needs of your own community is, rather than a diktat from the centre, is a very powerful agent for change if you mobilise that well.
Great. Let's stay with clinical commissioning groups. We have a question here which is the double whammy of clinical commissioning groups themselves having operational budgets which are decreasing. And the question is, therefore, do you consider that clinical commissioning groups have the resource to implement evaluative techniques such as STAR? And what's the role of CSUs in this? Gwyn, let's start with you, but both of you will have views, I know, on this.
I mean, for me, it's the phrase that sort of we think of STAR. It's Clement Attlee, Prime Minister of Few Words, was asked what it was like to be 80, to which he had this short reply: better than the alternative, basically. And that's, we all recognise that STAR is far from perfect. You know, in terms of canonical health services research, this would be seen as somewhat dirty and soiled and use all these subjective data, etc. But what's the alternative? So, you know, we would say that if you have to make these tough choices, you are going to have to take resources out. If you don't use this approach, if it's not informed by values, if you don't engage stakeholders, it's going to be very grim. And the point, I mean, I absolutely agree with the point Anita made about clinicians. You need to take clinicians with you. But the other point I'd say is that we find that by getting patients and carers involved, they're key in terms of how you estimate benefits. By having them all in the room at the same time, of course, the nature of the discussion is completely different if they're absent. And it also means that in terms of presenting these cases for changing resources, you've been through addressing their worries and concerns. So when you make the case to the public, or you have to say, this is why we're doing this, you can say, look, we've gone through this, we've engaged with patients and carers, these are concerns they've had, et cetera, you know. So so obviously I'm a less than objective observer of this.
Completely unbiased. We recognise that. We've taken that into account. Thank you. Anita?
I think there's a real difference between the ownership of the agenda and technical support. And so you're much more likely to deliver change, and there's no point in using these sorts of tools unless you can see through the change. Otherwise it's completely nugatory effort. If you've got your commissioners and other stakeholders really owning the analysis, you know, external analysis very rarely achieves that same buy-in. But I think there's probably quite a bit in STAR where you can have technical support in, you know, facilitation of the events, in how to use some of the evidence in the toolkit. And I would have thought that CSUs are definitely one potential source of help on that, and that is something for people to consider. The other thing to say always is that although I'm a big fan of local doesn't have to mean one clinical commissioning group. And my knowledge is strongest in London, where actually for my provider, I'm now on the board of Whittington, we have 2 clinical commissioning groups that work very closely together. And it obviously, groups of clinical commissioning groups may share similar issues and have similar interests, may be involved in the same provider who will probably be key to that service change. Okay. And there can be some pooling of resource there.
Great. Gwyn, there are a number of technical questions which, forgive me, I don't intend to have answered now, but would want them to be answered. I think this has been written up somewhere, hasn't it?
Yes,
would you mind just telling watchers where they could read more about this at the kind of technical end of it?
Well, there are 2 good accounts that the Health Foundation have published, very readable forms by Peter Davis, on a study in the Isle of Wight, which was at a time when there was growth money around, and that actually won a commissioning prize in the Strategic Health Authority. And that's coming out in the clinical decision making. And another study of the Sheffield one has been published in the Journal of Health Policy, Politics and Law. And this follows on a prize-winning paper looking at problems in estimating scale using disability-adjusted life years, published in Health Economics.
Very good. I like the sound of prize-winning. That sounds very, very reassuring. Let's move on and let's enjoy a disagreement with your argument here. Anita, here's somebody saying, I disagree with the insistence that I think is attributed to you, Anita, that transformative change is the only option to improve health services. I'm not sure this is what you meant, but here's the question. Continual political change causes disruption, drives up costs, reduces staff and patient outcomes where it's not evidence-based, and the process of implementation is not considered. Sweeping, poorly researched change, I'm sure this is not aimed at what you've been saying, Gwyn, only benefits the career of the commissioner and politician. What do you feel about that?
I absolutely agree that change for change's sake is completely inefficient. And let me be clear in this, I'm not suggesting structural reorganisation of the health service. I think pretty much all the research points to that being at best, divergence from this core agenda, and quite possibly has got in the way. What we're talking about really is change in services to deliver greater value. That is fundamentally different. We have a number of challenges to improve the health of our population, to improve the quality of healthcare for our population. What the Select Committee and others have been saying is that we progress on that agenda, which should be the real agenda, rather than just temporary holding down pay, has been too slow. We're not unique in that. All countries face the same challenges. The burden of the disease shifts to chronic disease. All countries recognise that there is huge potential in prevention. Everybody is struggling with how you actually really shift resources. Commissioning has been trying to think about that for 30 years, and at the moment has really struggled to make an impact. And I think commissioners really need to focus on that bigger picture. And that's really hard because there's so much stuff which is very focused on the short term and the transactional.
Okay, thank you. Various other issues being explored here. Let's see if we can open up the conversation a little more. I think people are very interested in this blend of approaches that you've come up with here, Gwyn, that you've got good economics, you've got a visual model, you've got a clarity of that the maths are really, really straightforward to anybody to understand. I now know why I learnt about the hypotenuse at school. I can understand that now, see how useful it is. And you've also got the ability to engage at the social level with the stakeholders. Yeah. How difficult is this? What do you have to do? There's no shortage of people telling or suggesting folks to do stuff. It's very busy out there.
Yes.
I work a lot in hospitals. And how do you persuade colleagues to do this?
I think that the key, I agree with the point Anita made, which is that you need external support. So an external facilitator is very important and helpful because it's clear to the people who are there, this person has no vested interest whatsoever in pursuing a particular service at the expense of others. And you need a facilitator who, although the models are transparent, need to be skilled into, the key thing is to get people to understand these are the sets of data you want on numbers, costs and value. we miss these data, then the process I described as to how you work out the missing benefits in terms of these are quality of life and working all that through. This is obviously, someone's skill to do that. But the other key element here is actually to have a product champion within the organisation who will drive this through. The most time-consuming thing in this exercise is actually getting hold of the data that are available, that ought to be available within the healthcare organisations. And because we ask for data to inform decisions, they're not readily there. But you have to have someone to drive that through and get it out. And also, in this approach, as in the Sheffield case, it involves getting the stakeholders to take 2 days out of their time, out of very busy schedules. So they have to be convinced that this is a worthwhile exercise. And there you're critically dependent on the champion in the organisation convincing people this is worth doing. Once they get engaged, then they get very animated. They think this is great and are very enthusiastic about it.
And you've got at least 2 hats here. If you were on a board and somebody's saying, come on, this is how we should be spending our time, how would you respond? And also you've got the bigger health foundation picture too. How might this be used? What's the case for it that you could advocate?
So thinking about the board position, we're all at the moment having to do the 2-year and the 5-year plan. I think for most organisations, both from a provider side as well as a commissioner side, the 5-year plan is really, really tough to add up. But also the other thing that's really important is, rightly, the NHS is emphasising the need for plans to be aligned. And that must be right, because if it doesn't work across a whole health economy, it's not sustainable. And I think all of us in the NHS then are struggling with a little bit about, we've got lots of bits of system process. We've got health and wellbeing boards, joint strategic needs assessment, joint planning around the Better Care Fund. But actually, how do we use those various processes to actually build alignment around the substance of what we're going to do and what we're going to have to change? And I think that's a really helpful hook, because in essence, this is a way for those very different groups to come together and develop a shared understanding across the pathway of what needs to change. And also to bring those organisations that have stakeholders that have a very different way of looking at things. I don't know if people engaged in the webinar are very used to doing joint working with local authorities. Where I am, we've done that for a long time. The language is very different, about how we talk about services. We're often talking about the same people. So for example, look at child and adolescent mental health or something like that. We're talking about the same people, but we have very different language to describe services.
The stakeholder groups have other functions as well that add real value.
Absolutely. So finding a way to structure that conversation, link it back then to what's the real change that we need to focus on and to affect, and why do we need to do that, is a really helpful way of cutting through a lot of that process and building alignment, I think. I mean, it's not inevitable. You could do all of that. You need good relationships, clear change programs, good leadership, resourcing, all that as well. But this potentially is a helpful way, I think, of creating a common dialogue and agenda for change, which is what is vital across all of those different initiatives.
Great. A question to you both, either of you or both of you. Would preventive interventions not usually show better value for money? And does this not weaken the case for using STAR repeatedly on different care pathways?
The answer is no, it doesn't weaken the case, it strengthens it. Because the whole, as in the example we gave of eating disorders, it's the early interventions. I mean, in a sense, it's not preventive because these women have already got slight anorexia. But whenever we do this work, you always find the earlier interventions are the more cost effective.
Yep.
But of course, you're caught in the problem which we're all familiar with, which is it's all very well, preventing stroke through control of blood pressure, but what do you do for people who've got strokes at the moment? So in the eating disorder case, it's the classic case where this intensive residential care is very poor value for money, but you can't stop doing it. You still have to treat these women who are seriously ill, who would otherwise die if they didn't get the care. So the issue is, how can you then move resources earlier in the care pathway, so you reduce the demand at this very expensive end to have much more cost-effective interventions earlier on.
So preventive versus in the situation is a false opposite in a sense.
Yeah,
you're
put it all
saying you've
together.
got to try and move the
Yes.
intervention earlier on.
Yeah, and because the thing is that there was a study done some time ago in the States where they just looked at preventive interventions and attempt to try and identify, because it's seen as the set of services that everyone talks about being very important, but in the end, no one ever does anything about it. This neglected service without the appeal of the life-saving acute interventions. So could we identify a top list of preventive interventions that we could really put our political support behind? And I think that's unhelpful, because I think, you want to put things in a care pathway and you get people together and they understand, when we did the eating disorder case, it's the first time all those people who provide care for people with eating disorders sat in the same room at the same time.
Yeah, back to that really overpowering social benefit. Absolutely. Anita, thoughts about that?
Well, I think there are a couple of things. One is obviously a lot of this is about early diagnosis as opposed to primary prevention. And we know, for example, in cancer, that one of the reasons why the UK has typically performed less well in terms of overall cancer internationally is because we've struggled with the early diagnosis phase. We've had that insight for quite some time and found it very difficult, actually, to really action change locally. So we need to continue to work on that. The other thing is, a lot of this as well, it seems to me, is about mobilising everybody in the system around that agenda. So if I take COPD, smoking cessation is, for people with COPD, very effective, very cost-effective intervention. Getting everybody in the system treating COPD patients mobilised around that, rather than just doing their bit very well, is incredibly important, potentially, to driving value. So one of the powers of STAR really is that look across the pathway, isn't it? And in bringing together everybody engaged in the pathway to agree on where we should be shifting resource, where we can really be driving value. Following on from that, presumably, is the action plan that says what's everybody in that pathway's role in actually achieving that change.
Thank you. Quick question to you both. What methodological alternatives, if any, exist to STAR? Are there other things that colleagues might be interested in?
Well, there's the obvious sort of closest approach is known as programme budgeting and marginal analysis, which has been around for a long time. And Mara Roldi, who's done the many of the key research in the applications of STAR, she just finished her doctoral thesis, and her criticism about the use of programme budgeting and marginal, there are two difficulties with it. One is that the way it works actually is you ask people, like in a CCG, which 6 things would you most like to expand and which 6 things would you most like to cut back on to release resources for expansion. The difficulty is, if you don't look across a care pathway, people say, well, I don't know if I cut resources on this particular intervention, what the effects will be on other services. So although I'd quite like to do that, I'd like to know what's going to happen. Yeah. And it's the lesson from programme budgeting and marginal analysis is why, when we look at reallocation, we organise that across a care pathway, because then you can understand the ramifications of different changes. And the other issue is that within programme budgeting and marginal analysis, there's this problem about what method do you use to assess the value of the different interventions. And in a sense, it's argued that what they should do is what we do, which comes from cost-effectiveness analysis. But they typically tend not to do that. So there's a lack of, in the studies that have been published, there tends to be a lack of rigour in how people assess value. So although this is subjective, it is based on a rigorous economic principles to estimate value.
And when you were talking to patients and carers and service users and indeed clinicians, did they understand that? Were they happy with the way you were going about are judging value? Because it's not a concept,
Yes.
we know about cost, and any
Yes.
patient can tell you
Yes.
about that, but value is quite subjective, isn't it?
Yes, but I think again, we're back into what is the alternative,
Yes.
which is that this is of course a subjective estimate, but the other key strength of this approach is that what they do, and you demonstrate to them, because you start off saying, look, this is the data that we've got, these are the data that are missing, we're missing data on value, we all agree this is absolutely vital, let's go through this exercise, let's estimate what value would be for different interventions. We now put it into what we call the efficiency frontier. This tells us that, intensive residential care is very poor value for money. Now, we had a range of estimates for what that might be in terms of probability. Let's play around with these and see if it changes very much. And the answer is spending £1 million on 16 people, they're not transformed through this process. Of course, if you're at the severe end of illness, you don't get this transformation states of health. So it's going to be a relatively small increase. And then you think about, well, should we move it through? So the point is that not only do they see this is filling out a key piece of information on value, but it's grounded in the sense of this is what the decisions would look like.
Yeah, okay. And with your economic hat on, how do you deal with value? What's your sense of this, Anita? Is this a helpful move towards a bit more precision here, or where are you coming from?
I come back to what the point of the health service is. And I think this is really important at the moment because, and it's funny to say this as someone who writes a lot of this stuff, it's so easy at the moment to get locked in a focus on finance. And actually, although the money matters, actually isn't the point of the healthcare system. The point of the healthcare system is to deliver improvements in care and ultimately, you hope, in health outcomes. We spend a lot of money on healthcare. We spend a lot of public money on healthcare. We owe it to the taxpayer and to the patient to make sure that as all of that money is focused on where it can deliver best impact. And that's important always and forever, but never more so when you're facing really tough decisions because of the financial squeeze. So I don't think really that we can hold our head up within the NHS and look either patient or taxpayer in the eye unless we really do focus on value and remember that and have that as the core of what we do.
Very good. We're coming to the close of our time. It's not too late to send us any comments that you might have, especially if you're simply interested in having a dialogue with either Anita or Gwyn, because we can follow up with you afterwards. One more specific question, then I'm going to invite both of our speakers just to give us their final reflections really on this topic. And it's a very specific one for you, Gwyn, about whether or not STAR can be used between care pathways as opposed to just within one pathway.
In principle, yes. But in practice, I think that given where healthcare systems are at, not just the NHS, it's so hard to do it within a care pathway. I think it's much better to stick, for now, working within a care pathway, within a disease. People feel comfortable about that. Once we've done that for a number of years, and so you could be confident that we're spending money on cancer in the best way we possibly could, we could then begin to explore, should we move money from cancer to mental health or the other way around? Great.
15 seconds, no pressure. Where would you like to leave us on this topic?
I think on the real value in using something like this to bring stakeholders together to really actually achieve change. Many of the things that STAR will reveal have been well known for years, like early diagnosis in cancer. But actually achieving change requires mobilisation of stakeholders.
Great. And just a last thought, Gwyn, if it's a very quick one.
Okay, quick. I think what I'd say is that a conventional approach says we can't involve stakeholders because we don't have data on value.
Yep.
And we'd say that through STAR, you engage stakeholders, and that's the way in which you actually get much better data on value.
Great. So, thank you. Our time is at an end. My thanks to Gwyn and to Anita for a wonderfully stimulating hour. And huge thanks to all of you who've contributed. All of us at the Health Foundation hope you have really enjoyed this webinar and found it practically useful and thought-provoking. If you are taking part today, then by definition we have your email and we'll be alerting you about our next webinar in the autumn. Before we close, let me ask you once more to give a resounding digital round of applause to our two contributors today. Thank you very much.